Hi everyone, my name is Shad Yasin. Again, I'm a rising second year medical student. I go to Rutgers, New Jersey Medical School in Newark, New Jersey. Let me share my screen and we'll get started with it. So thank you all again so much for joining us tonight. Betty described a little bit about our internship, sort of centered around health policy, looking at the international context of healthcare as well as healthcare systems, sort of proposals on both sides of the aisle. And within that internship, we did get to learn a little bit about how free markets could potentially work in healthcare. Obviously, here at One Payer States, we believe in a different route, and I think it's important to know why we don't think that free markets are exactly the solution to our healthcare problem. And so today, this is exactly what we're going to be talking about. We're going to look into why the free market can't solve our healthcare crisis. And so here are the 7 principles of the free market. This is sort of the major principles behind the free market, free competition that really apply, or at least the sort of libertarian conservative viewpoint believes applies to our healthcare. Number 1, we have large numbers of buyers and sellers within the system. And so that means you have a large number of producers and a large number of consumers. Number 2, you have a homogeneous product, meaning that all of the producers are producing similar products so they can compete against each other. Number 3, you have no entry or exit barriers for either the producers or the consumers. Number 4, you have perfect information, meaning that the producers and the consumers all have perfect information on each other as well as on the product. Number 5, you have that the benefits come only from payment. So only if you pay into the system will you benefit from that. On the other hand, number 6, you have that the price accounts for all the costs associated with creating the product, producing the product, selling the product. And number 7, profit maximization at the end of the day will always be the name of the game for the free market. And so let's take a deep dive into all of this, all of these core principles of the free market. And to do so, I thought it might be good to look at examples, compare one product to healthcare. And so I thought, why not just pick something simple as a pencil? And so we're going to be looking at a pencil versus healthcare, and how does the free market work with both of these things. And so when we're looking at the large numbers of buyers and sellers, in the example with a pencil, right, you have a large number of pencil manufacturers that exist in the world. You have Ticonderoga, Dixon, Papermate, all of these manufacturers are producing pencils and selling pencils. Billions of pencils are being sold every year. And so you have a large number of consumers on one end, and you also have a large number of producers on the other end. Because of that, the price of the actual pencil is not created by the producer itself. It's actually created by the market. What is the market willing to pay for one single pencil? And so instead of being a price maker, the manufacturers of those pencils are price takers. They take whatever price that the market will drive. And so both manufacturers and consumers are price takers in this scenario. Healthcare is a little bit different. In most of the country, there is not a whole lot of hospitals and clinics available to us. I'm not exactly sure where all of you are from, but I'm sure a lot of you are well aware of the crisis of rural healthcare in America today, that we don't have a whole lot of clinics in rural areas. We don't have a lot of physicians in rural areas, but in general, these areas are sparsely populated. And I want to show you a map really quickly. That so this is a map of the United States, and the black areas are areas of the United States that are densely populated enough for competition to actually work within healthcare. The white areas are areas that are too sparsely populated for competition to actually work in healthcare. And so we see that half of Americans live in areas where the population is just simply too low for there to actually be a competitive market for healthcare within that area. And so you have hospitals and clinics that you have maybe one hospital in an area, right? So you only have one real producer in that area and many, many consumers. So that hospital can decide whatever price it wants to give you because the consumer, the patient, has nowhere else to go. And so hospitals end up being the price makers. They make the price that they want. They decide the price that they want to set for a particular procedure. And now patients are actually price takers. They have to take whatever price that the hospitals decide. The second thing is that in a perfect competition, you have to have a homogeneous product, meaning that all the sellers sell a similar product. And so in the case of a pencil, pencils are all the same. A Dixon pencil versus a Ticonderoga pencil is going to be a similar pencil. It's going to be a similar product, regardless of what the manufacturer is. Quality at particular price points are going to be roughly the same with them. With healthcare, again, it's a little bit different. You have different types of physicians. You have different physicians, different nurse practitioners, physician associates that are offering different opinions, different treatment plans. For example, if I have shoulder pain and I go to 2 different doctors, one doctor will suggest to me to go to physical therapy. Another doctor will refer me to an orthopedic surgeon. And so those are 2 different opinions, 2 different treatment plans for me that will accrue 2 different costs as well. And so there isn't a homogeneous product being sold here from a physician standpoint. So healthcare really isn't the same wherever you go. It's not the same to whatever physician you go to or whatever healthcare provider you go to. The other point is that quality is a little bit difficult to measure. We talk a little bit about, if you've ever looked into quality metrics in terms of payment models, quality metrics, in terms of like how good of a doctor do you have in your area, you'll know that it's a little bit difficult to determine what makes a good doctor. What qualities am I looking for in a good doctor? It's pretty difficult to determine that, and it's actually incredibly difficult for insurance providers to determine that. It's incredibly difficult for hospitals to determine that, because quality metrics themselves, it's a lot of the things that actually matter in terms of quality metrics are actually very, very difficult to measure. And so that's what becomes difficult about healthcare. You don't really have a homogeneous product being sold here. The third thing is that there are no entry or exit barriers in perfect competition. If I want to go sell a pencil, I can do so without any real legal or societal restrictions holding me back from entering into the market. As a consumer, I can go to Staples, Office Depot, and buy whatever pencil I want to. Or, you know what, I'll say, I don't want to buy any pencils anymore. I just want to buy pens for the rest of my life. I can do so. I can exit that market freely. There's a lot of mobility within the market that I can do very freely. Healthcare, again, it's very different in this case. Healthcare providers require trainings, they require licenses to provide care. In a free market, perfect competition scenario, I could wake up one day and say, you know what, I want to be an orthopedic surgeon today. And I could do that. I would personally like to live in a world where no one can just wake up and say they want to be an orthopedic surgeon today. I would want my orthopedic surgeon to have training. I would want them to have a license. I would want them to have real life practice to be able to operate on me in a hospital. And so it's really important that you have these things, you have these barriers for people to actually enter into the market, because it's important, because these are people's lives on the line over here. The other thing is that patients on the demand side, patients don't have much of a choice to enter or exit into the healthcare market. You don't really have a choice to get healthcare or not get healthcare. You're either going to get treated for your condition, or you're going to let your condition go and you're not going to do well. And so you don't really have much of a choice there. We also see with increasing numbers of smaller networks because of insurance providers, that you have much less choice than you previously did. And you also need to know that when you have necessary treatments that you just have to get done, you have to have a mandatory surgery. It's not an elective procedure. You don't really have much of a choice in the market to decide, you know what, I'm gonna I'm going to decide not to go to the hospital and get this procedure done. It's not really an option there. In a free market, you also have perfect information. In the example of the pencil, if I go to Staples, if I go to Office Depot, I have all of the options of pencils right in front of me. I can choose between Ticonderoga, Dixon, Papermate, whatever pencil companies are out there. I can choose, and all of those options are right in front of me, laid out in front of me, prices listed and everything. I don't need to research a whole lot. I don't need to do a whole lot. I don't need to know a whole lot before going into Staples or Office Depot and trying to buy my pencil. I have easy access to all of the options, and I have easy access to all of the information that's required for me to buy that pencil. In healthcare, it's a lot harder to know what you need to know to shop around, number one. And number two, it's hard to shop around in general. And so what I mean by that is, again, going back to the quality metric that we were talking about earlier, how do you know whether your physician is going to be good or bad? It's really difficult to tell whether your physician is going to be good or bad. And it's difficult to shop around in general in healthcare because most scenarios, you don't really have much of a choice. You either have a hospital that is close by or a hospital that's 30 miles away. You're going to go to the hospital that's closer to you because this is probably a scenario where you want to go get a procedure done. Emergency scenarios specifically, you don't have any options. Before you have an emergency scenario, you don't get to research your ER physician and see whether that ER physician is a good doctor before you go there. You just go there, you get treated, and then you come back. You don't have information about your provider, your producer in this scenario, before you buy that product, before you get treated. Number 5 is that benefits only come from the product if you pay into that product. And so in the pencil example, for the most part, if I buy the pencil, I will accrue all the benefits from the pencil. Society will not get any benefits from me having a pencil to write with. It doesn't help society in any way for me to have a pencil. Whereas in healthcare, it's a little bit different. Healthcare does actually have an effect on society. And this is what begs the question of, should we pay for people who can't afford healthcare? And this is a question that has come up a lot in our history, and it shouldn't be coming up because I'm assuming most of us in our crowd today would agree that we should pay for people who can't afford healthcare because their benefits actually go to society. Everyone benefits from having a healthy individual within the society. And we're actually going to have a breakout room specifically about this topic. This is what we call in sort of economics terms an externality. Sort of something that's, you're paying something into the market, it's a benefit or a negative externality. In this case, it's a positive externality. A benefit that you're accruing, society is accruing, even though their society is not paying into that product, even though society is not paying into that individual person's healthcare, society is benefiting from everybody's healthcare. And so I want you to start thinking about this because we are going to have a breakout room just to talk a little bit about examples of this. How can we use examples to talk to people about and advocate for the things we want? Our 6th principle is that price accounts for all costs of the product. And so in our pencil example, price is driven primarily by market forces. If Ticonderoga wants to start selling a $10 pencil, there's so many sellers, there's so many producers that they really can't because they have to compete with that $10 pencil. On the other side, no one's going to pay for a $10 pencil. There might be a small percentage of people that'll pay, but because there's so many consumers, for the most part, the market will not handle that $10 pencil. And so price is going to account for that. Price is also driven by that market, and it's generally accounted for. It generally accounts for all labor costs, all manufacturing costs, and all infrastructure costs that are associated with producing that pencil. The problem with this is that sometimes the pencil, this example doesn't quite include negative externalities, meaning like the manufacturing plant for the pencil might have environmental damage. It might produce environmental damage. And the cost of that $1 pencil doesn't really include that environmental damage. But for the most part, it includes most of the costs that are associated with that pencil. In healthcare, hospitals and clinics are, again, the price makers. And so they have no reason to not price out things much higher than it needs to. And so you see this in a lot of excessive administrative burden. You see this where hospitals are sort of price gouging procedures because they know that they have the ability to. And so it makes these prices not accounting for just all the costs, but also excessive profits as well. You see this in the drug manufacturing industry as well. The other thing is that price will account for the costs of others' care as well, not just individual care. If I go to a private insurance company today and I pay my deductible, I pay my premiums, that money is going into a stockpile. And whenever anybody gets sick within my little group of insured people, anyone takes the money out of there. And so I'm paying for somebody else's healthcare already. It's not just my cost, it's already somebody else's cost. And most plans are going to be like this. And so healthcare in general requires people to sort of pay for other people's as well. And the final thing I want to say is that profit maximization at the end of the day is always going to be the biggest game there is. And for the example of a pencil, right? Ticonderoga as a company is going to have shareholders, it's going to have people, executives, they're going to be selling that pencil to consumers, but they don't care what happens to the pencil afterwards. They care about their profits. They want to make sure that the company is profitable and they're making money afterwards. They're profit motivated, and that's okay for a pencil company to do. In healthcare, it's not as okay for that to happen. You have executives that are making money and making profits out of this. But the problem is we don't want to have healthcare because it's profit motivated. We want to have healthcare that is patient centric, that is only for patients when they need it, providing the proper care that they need. And so it shouldn't be profit motivated. It needs to be something else. It needs to be patient centric. It needs to be demand motivated. And so that's a problem with the profit maximization of free markets. And so looking at all of these principles, I hope we sort of went through the majority of these, any questions that you might have had about these principles, anything you've heard about these principles. And I hope that you could sort of get something out of this. I want to stop right now and see if anyone has any questions. We have one question for the breakout room. We're going to do a 10-minute discussion in the groups, and then we're going to do a Jamboard, which Betty mentioned at the beginning. We're going to explain to you how that all works when you come back from the breakout room, and we want to put the stuff on the Jamboard. But the question is, it's about those externalities that we were just discussing. What externalities interfere with the free market operating properly in healthcare? And what I mean by that is, what sort of situations, what examples can you think of that prevent healthcare from following these free market principles, that have healthcare be a benefit to society as a whole and not just the individual, for example? And so, yeah, that's sort of what I want everybody to think about. I'll put this question in the chat so that way everybody has it when they go off to the breakout room. And yeah, let's get discussing. Okay, so I am going to put a link for the Jamboard that we have. And essentially it's just this website where we can all just type in our ideas that we talked about in the breakout room underneath the question that is listed at the top, the question that we were just discussing. So if you just click on that link to go to the Jamboard, you should be able to see the question at the top. And then on the side, you have all these little options with the pen, eraser, everything. All you need to do is just click the text box and then just start typing away. I can share my screen and show if that makes it a little bit easier. So you can either make a sticky note like this and start typing the sticky note, or you can make a text box like this and start typing here. Okay, so we have a lot of ideas on here. Thank you all so much for participating. I'm gonna start looking through these, and we might be able to pick out a few and have people sort of talk a little more about what they were talking about on here. Yeah, so I'm seeing the pandemic as an externality. That's a really, really good example of whoever put that down, if they feel comfortable talking a little bit about that, that would be great.
And I put that down.
So could you tell us a little bit more about what you meant?
My idea wasn't completely developed, I'll just tell you that, but I do believe it is an externality because we as a for-profit driven system have not been prepared for public health. So the pandemic, we couldn't account for everything that the pandemic was throwing at us. And therefore it is ultimately an externality here. We could not be prepared because we don't prepare ourselves for public health, and that's what Medicare for all, healthcare for all, single payer system, even NHS is better prepared to deal with. And you know that even the NHS in England has been under attack by privatization over the years, lending them not to be able to, um, fight against the pandemic as best as they could. But an example like in Taiwan, you know, where they had better outcomes.
And then my second one is severe natural disasters, especially with climate change. That throws the whole system off.
There's a lot of these moments where you have the health of these individuals, taking care of individual people, helping sort of society as a whole, especially, and I think COVID, these natural disasters, I think these are really good examples of them. Specifically COVID, one thing that Dr. Marvin Malik was bringing up in our breakout room was the COVID vaccine, and how the COVID vaccine, if you have an individual taking the vaccine, that helps significantly for the society. Dr. Malik, you have your hand up.
So a lot of the people who've written on this Jamboard have talked about the fact that treatment of a disease, say high blood pressure now, will become very expensive later if it's left untreated. In 18 years, the patient might have a stroke. But one of the issues with the US healthcare system is that we're supposed to be shopping for insurance companies every year, and the average person stays with their current insurance company somewhere around a couple of years only. So your current insurer may not have much motivation to get you treated really well, because they're not going to be hit in 18 years when things get really expensive and you have a stroke. So that's one of the issues with a single payer system. It's sort of an externality of having high blood pressure, because that insurance company is not incorporating that cost. It's a very odd kind of externality. It's a very strange one, but it probably is one because of the instability in insurance coverage.
So some of the externalities we were talking about may actually fit under other categories for which principle it is. But as far as infectious diseases, they're clearly an externality, because if one person has an infectious disease and they don't get treated, then other people get it too. So the rest of society all benefits if somebody with an infectious disease gets treated, so that we don't all get it. In the pandemic, that's been particularly crystal clear. Which also has been clear with tuberculosis and HIV, typhoid when it's gone around. So there's many things where it's beneficial to have people get the treatment so that it doesn't spread to other people.
I think at this point it's embedded in the American DNA that we blame ourselves. We blame ourselves for getting sick. We blame ourselves for not being able to afford the health care. And why would there not be outrage over this pandemic? And why wouldn't we be breaking down the doors of our representatives to get Medicare for all? Because ultimately, I believe that Americans, after being subjugated, to for-profit, for wealthy, ultra-wealthy individuals, and the pursuit of that itself, pursuit of that themselves, wanting to be that billionaire or whatever, has it in their DNA that they wouldn't do this type of thing. They wouldn't fight for this when it should be their right.
I think it's really important that we make clear as we're trying to move forward the proposition of trying to get healthcare for all, is that it should absolutely be nonpartisan, that this should not be related to any particular party. In no other country is it considered as partisan, is it even considered partisan at all. Within some other countries, for instance, in the UK, there can be some conservative parties that may sometimes be trying to figure out how to use the free market in some way so that they can, extract profit from the system somewhere. But that's only like a small part of their conservative party. Most of the conservative party says, yeah, this is like a public good that we need to do for each other. And it's really fairly unique to the United States to have this polarization around this topic.
It should be such an easy sell.
Well, it is really difficult.
Product, it costs less. There's no extra, there's money's already been allocated for it. We're already putting it in. And it's just so easy for them to sort of put their finger in the gears and stop the whole thing. They don't have to really make the partners for the future of American healthcare or whatever. They don't have to make a case. They just have to unmake your case. And they just have to pull a string to get it, and they can do it amazingly well. And of course, they've got more money than God. So, and no qualms about not doing it. I think they're right.
I've studied the English health system in the last few months. They only spend 9% of their GDP on healthcare. Every other country in Europe spends 11 or 12%. The National Health Service in England is far and away the best healthcare system in the world, but it is being badly hurt by the politicians, and that goes back to the Blair administration. It's not new. They take advantage of how good their healthcare system is. So Barbara brought up a whole nother set of topics about what we have to do to address the challenges of the health insurance industry. I'm already on a new topic, so I'll leave it at that. I don't want to take up too much time. Thank you.
So I do see someone put in the comments that in the chat that Republicans Nixon and Bush added improvements to Medicare. So it is important that we acknowledge that it's Medicare is a popular program, and it should not be partisan. And people from both sides of the aisle, or all sides of the aisle, for those of us who think of us as having more than two parties, should be looking to how to improve this system, including expanding it and improving it.
Do you guys think that one way the single payer movement can move forward, and I think OPS strives to do, is also trying to, make things more nonpartisan, bring more people into the fold?
Yeah, I can speak for one of our contributors is Warren George, who's a registered Republican and ideologically conservative. He used to manage a factory here near Corvallis. And he knows the language of his conservative friends and partners. And he tells us that we can speak that language too. We just have to avoid certain red flags that are almost part of our religion. Condemning corporations in general, or saying big business. Those are red flags to people that we might otherwise convince to join us.
Oh, good point.
Right. It's really important when people with different perspectives engage with us that we welcome them in warmly. Sometimes it's harder for some people, for people who are already independent voters, it may be easier than for people who already belong to a political party, but we do need to make those extra efforts to engage in conversation with people from outside of our usual circles. And that goes for everyone.
In in Al Sayed's book, a comment, a little quip by Jayapal, that she says Republican congressmen come up to her and say, I don't agree with anything you do, but would you please get Medicare for all through?
Really? Right.
Actually, it might actually be business people and not other congressmen. But I don't like anything you stand for. But would you please do this one so that we can get the health care off our backs?
And when I first went on Medicare, it was very hard to find a doctor that would take me because their payment to the Medicare doctors, or the Medicare payment, was so low. How do we solve that problem? How do we get the doctors on our side?
I know.
And I had a nephew in Canada. They lived in Canada. He had a hematoma on his head, and the doctor they were to see, he had already earned his maximum income and couldn't start it. So these are stories I'm hearing. What's our answer to those things? I'm new, so maybe you've done this before, but.
So John said over 50 MDs are on salary. Yeah. So in terms of getting doctors on board, the one thing is that most doctors actually do support a Medicare for all proposal. Most doctors in the United States do support that. The other thing is that there's a lot of benefits to a Medicare for all system, at least the ones that have been proposed recently to doctors themselves. There have been estimates on sort of like the payment for doctors and how much will it actually reduce doctors' salaries. And they've done these estimates, and it's either going to stay the same. There's actually estimates that it might increase their salaries because we're reducing so much waste in our system that we have so much money left over. And so if we wanted to spend exactly the same amount as we do right now, not increase spending, not even decrease spending, we could give doctors raises, or we can keep down the prices of everything, have taxes lower for everybody as well, and reduce prices or keep physicians' pay roughly the same. And so most doctors will be paid relatively similar to what they are right now.
So what about a very, very, very good surgeon who people wait months to see? I mean, I'm playing the devil's advocate because I have to explain this to my friends. And
well, maybe I don't know how to raise my hand virtually on here. I can't find it, but I'm a retired physician and I'm with Physicians for a National Health Program. And when you look at the salaries Canadian physicians make, they're generally on par with what American physicians make, although primary care doctors make more in Canada, which is one reason why American physicians are now going to Canada to practice, as well as because of the reduced administrative burdens for physicians in Canada. And one of the problems with our system is you are correct. Physicians can pick and choose which insurances they want to accept. And a lot of physicians and specialists will not accept Medi-Cal, Medicaid patients. Some won't accept Obamacare patients, and some won't accept Medicare patients. So our idea of giving people more Medi-Cal, more Obamacare, you can give them insurance cards, but you're not giving them access to care because so many physicians still won't accept those insurances. In Canada, everyone has access to care. The physician gets paid the same amount because there is no insurance. So the physician will be paid the same amount, fee for service, for every patient who comes in the door. And that ensures universal access to care.
So does that keep the doctor from keeping up on his education and getting better at his practice if it's not going to mean any difference in his income?
Well, it is fee for service. So the busier you are, the more money you will make. And there are still going to be educational standards for continuing medical education like there are in the United States. So I don't see where that would have a negative impact of quality of care.
Okay.
Hi, Dr. Healy. This is Lynn.
Hi.
Hi. I've always wondered how Canadians pay for health care. Do they do payroll taxes?
Well, I believe it may be a combination of income tax and payroll taxes. There may be other people here who can answer that part of it better than I can.
Because it's province-based, it's not one uniform system across the whole country. So some of the federal taxation goes into it, and then there's also provincial.
David has his hand up.
I agree. I think it is a provincial system, so the financing is going to vary. I wanted to say that I wouldn't worry that finance has anything to do with doctors continuing their education, because that's going to be driven by licensing and by certification. That requires continuous medical education. It has nothing to do with how much one is paid. It has to do with keeping a license to practice.
Okay, I didn't know.
And actually, in some of these systems, the public administration portion of it actually plans some of the CME, rather than having the continuing medical education being planned by pharmaceutical companies trying to sell you drugs. It's actually planned by the public administration, and they'll figure out, okay, this is stuff that, when we look at the data, because we have one single system, we can look across the data that comes in from everywhere and be able to see, are we not doing as well on controlling blood pressures, or are various things they can look at and decide what kind of CME they should be developing and making accessible to the providers. And because the providers are not pushed to have to see so many patients to try to meet their requirements for their employer, there's more time built in to actually do the CME rather than having to go off on a trip to get your CME.
Okay.
Of course, that's variable depending on the country, but I've heard that specifically about the UK. David, did you have something more? Did you want to put your hand down?
So I remember now there's the research I did in Canada, there's 13 provinces, include some of the islands and stuff. So I'm thinking in my head, that's kind of like what we're doing. If states got their own plan, then the federal government's money, 71%, would come into the state, and the state would figure out how to pay for the 29%. Is that sort of like the Canadian system? If we had state by state single payer?
To some degree, it would depend on, like some states don't even have an income tax, but they would be getting federal monies from the money that is currently collected, for instance, for Medicare and Medicaid. That would be a block grant probably to the state. But all these things are sort of hypothetical. We're not sure how it would be done. We just know that it can be done. We know there's enough money currently going into the system to more than pay for it. We're just not getting it. So, exactly, any of these options would be better than what we're doing right now.
Right.
Now I'm seeing a couple of comments in the chat here that medical practice would be lower because the future medical care is covered. That's right. And Dr. Malik from Vermont had noted that in Vermont, we actually do have our CME around opioid prescribing provided by the state, and they go around to hospitals and do the grand rounds for opioid prescribing and pain control. And another topic that might be like polypharmacy in the elderly and that sort of thing. So states have that option that they can do that. So it just depends if they see something's a huge enough need that they decide to go forward and provide that to hospitals and clinics. Barbara Cummins?
I put in the chat the 20-year basically overview of health on Wall Street. Okay, and if you go to it and put in 20 years, you're going to see what a tremendous growth since 2010, which is when the Affordable Care Act passed. Investor wealth is a big problem. And it never gets discussed when it comes to healthcare, but believe me, everybody's involved in it. My public pension fund, CalPERS, big time. Union funds, anybody Any nonprofits that hold excess revenue usually invest the money, and it's probably with healthcare in part, okay? So if you have an opportunity to bring this up to your groups, talk about it, because we have to find a solution. One, the healthcare does not need this capital, but climate control does. There has to be a way for people to divest and put their money where it's really true capitalism. Okay, and then the other thing I want to say is we have been waiting 56 years to get this right. Medicare just turned 56. Okay, no more stalling, no more waiting. We have got to go on the offense if it takes going to the federal buildings across this country until they do it. I really want to encourage people. We have to go on the offense with this. We've been playing nice too long.
Yeah.
Thank you.
Thank you.
So we're going to be talking a little bit about overutilization of care. We're going to talk a little bit more about
Where?
this.
In Japan?
Yes, that's one example. But there's a big concern that a lot of people have that if we go to a single payer system, everyone's going to go to the doctor willy-nilly. And so we want to talk a little bit about what that concern is really like and what that concern is on. How do countries sort of take care of that concern that might come up if that problem comes up?
And don't we have we have evidence in our country that it didn't happen?
Yeah. That we have
all the times it could have happened, it didn't happen.
No.
I'm Shivani. So as Dr. Keller mentioned earlier, I'm a rising second year at LSU School of Medicine in New Orleans. I actually had done graduate work in cancer genetics, epidemiology, and public health previously, and have experienced the UK healthcare system while living and working there, as well as in different parts of West Africa, and Haiti, and Ecuador. And I went to undergrad at Emory, doing sociology and biochem. So I have a pretty broad mixed background, but I was really excited to take part in the PNHP internship this summer and learn just enormous wealth of information. It's going to serve well in advocating for single payer. And I'll turn it over to Simran to quickly introduce herself too.
Hi, everybody. I'm Simran. So nice to meet you. I'm also a rising second year at the Stony Brook School of Medicine on Long Island, New York. I've had a longstanding interest in public health and justice in healthcare, led me to pursue a bachelor's in public health at the University of Rochester, after which I did an AmeriCorps service year in Brooklyn, New York, where I was helping uninsured patients get access to their medication. So a lot of my experiences have just showed me how much our healthcare system fails the people who need healthcare the most in a lot of ways. So also was really grateful and excited about the opportunity to learn more about single payer and how to advocate it, especially as a future physician. I'll throw it back to Shivani. We're going to talk a little bit about the problem of overutilization and how some countries have gone about addressing it.
Okay, so, really, as Simran mentioned and Shad alluded to earlier, people are going to say, well, okay, if we bring this into the fold, will people start going to the doctors like willy-nilly? Will they overutilize the system? How can it just maintain and be sustainable enough? And we know, as we were just having that little discussion, that really these arguments don't prove to hold, don't hold up in this data sense, that we actually don't see overutilization. But then we also thought it'd be interesting to present an international look at how other countries have dealt with this, either preventatively or reactively. So question we wanted to open with was, what concerns might some people have regarding overutilization in a system without copays or other financial barriers to access to care? And how might we want to address these concerns as we design a system for the US here? Considering also we're at one pair states, what have you all thought about? I think.
So I put this question here as just like a contextualizer. And now we can discuss the different countries and then go into breakouts at the end of that discussion with this question.
You wanted to make sure we're not going to breakout room just yet. Mm-hmm. Okay. So the first country we're going to bring up is France. So really, just we try to simplify this because we know this is going to be a long discussion. If we wanted to, we could go into the history. A lot of us researched into different countries' healthcare systems, but looking more just at the macrocosm of overutilization issue, France, with its statutory healthcare insurance, did see a rise in more GP visits as well as in drug prescriptions that were overutilized. They did some studies after expanding their healthcare coverage, which really was interesting, incrementally, intentionally done to bring everybody with the fold. They did see some problems with this. Unfortunately, the healthcare costs just could not keep, were overbounding the percent of GDP, even more than the UK and other countries. The drug formulary ran into problems, so much so that they actually ditched their national formulary, which is really sad, unfortunately. And really also they saw physicians being overwhelmed and overworked and going on strike in true French fashion. And so they were like, yeah, we definitely need to address our utilization. They acted more reactively. And so they looked at two main strategizing ways to do so. For a while, they focused on strict accounting, cost containment policies, and a lot of this had to do in the 90s, especially with stricter gatekeeping and some even legal tariffs that they imposed. One big component of this was reducing the benefit basket of what people could get, the levels of coverage, making co-payments and insurance more likely to go up for people in terms of what they were contributing and not getting reimbursed back at the end of the month or end of the week. So this, went on for a bit. Unfortunately, people really were not happy with this, physicians included, with these strict accounting cost containment policies. It did not last. So they turned their eyes to more medically based cost containment policies. And with this, it actually gets back into what we were talking about a little bit earlier. They're wanting to put the focus more on continuing medical education, really ramping up professionalism in the field and actually implementing national practice guidelines, rewarding good behavior, rewarding really positive interactions with patients, as well as keeping costs down while providing the right amount of care for whatever differential diagnosis the physician came with. And interestingly, physicians entered agreements that were mandated with the statutory health insurance. These collective agreements came about. And overall, this, as opposed to the more punitive measures, seem to work and have maintained since. So with a little bit of trial and error, France was able to get to a place with a little bit more cost control from their overutilization problem. And for the sake of time, I'm going to turn it to Simran, who's going to talk about Taiwan and the UK briefly.
Yeah, so Taiwan gets a lot of attention when discussing healthcare policy because they're unique in that they kind of called all the experts to rehash their system. So it's really interesting to look at kind of how they address their overutilization problems. Shivani, can you advance the slide for me? So Taiwan is really interesting because they have really limited cost sharing. Their copays are like, I think on the order of like $3 US for a primary care physician. And on top of that, there's no gatekeeping at all. So essentially, if you're a patient and you're like, my ear kind of hurts, like there's nothing stopping you from going to an ENT. So because of this, the Taiwanese people really love their healthcare and they use it a lot. And that poses a bit of a problem for the system. There's very crowded hospitals, there's very overworked doctors. Doctors on average in Taiwan work about 10 hours more a week than doctors in the United States. And in general, it just means that resources are spread pretty thin. Next slide, Shivani. So they have also kind of thought of some ways to deal with this. And again, I kind of saw that there was two prongs to their approach. There's some provider-focused strategies. So these include enhancing the capacity of primary care, trying to get more primary care doctors into the fold that can see patients before it's time to send them off to a specialist, and also increasing payments for critical care over minor treatments. So this is a way to incentivize hospitals to spend more resources on critical conditions as opposed to minor treatments that patients might be coming to the ED with. There's also the other prong, which is patient-focused strategies. So one is to strengthen the public's capacity for self-care, like telling patients, listen, you don't really need to go to the doctor for this issue. Maybe try this remedy, or you can easily pick up hydrocortisone for your rash at the pharmacy. You don't need to see a doctor about this. And another thing they've been doing is incentivizing use of a referral system. So I mentioned earlier that patients in Taiwan don't necessarily need a referral to see a specialist, but they've built into this system an incentive whereby their copay is even less to see a specialist if they go to a general practitioner first and get the okay from the general practitioner to then see a specialist. So those are the strategies used by Taiwan. Shivani, next slide. And then here is a Union Jack, because now we're going to talk about the UK a little bit. Next slide. So I looked into the overutilization in the United Kingdom, and interestingly, it's not that huge of a problem. It's not significantly discussed, even though people talk about wait times in the UK all the time, which I thought was really interesting. There are some endeavors underway to try and just really enhance the capacity of primary care and work with GPs to reduce unnecessary referrals as a way to maintain efficiency. But overall, it doesn't seem to be the problem or the nightmare that people describe it as here in the United States. So yeah, that just begins the discussion of wait times. And I can just talk a little bit about the reality of that as opposed to what people tend to think. There's actually maximums put in place for the UK. So for non-urgent referrals, the maximum time you're allowed to be waiting for an appointment is 18 weeks. And for urgent referrals, such as in the case of cancer, the maximum time you should be waiting is 2 weeks. And in the meantime, it's not like you're not allowed to access care at all. You still have access to appropriate and necessary care in the meantime. So interestingly, in 2016, 57% of citizens of the United Kingdom were able to make a same or next day appointment, whereas only 51% of people in the United States were able to do so. So it kind of turns the paradigm of wait times on its head. And I just wanted to add that I saw a really great point that, you know, this 51% is coming from individuals with insurance, but for the 10% of Americans who are uninsured, their wait times are essentially infinite. And I think Lynn kind of hit the nail right as well, right on the head. The uninsured have a permanent wait, exactly. So just kind of trying to think about everybody in the United States and how that's affecting these numbers.
Thank you so much.
Okay, so I think we're ready for another set of breakout groups. So just again, the question that we started this discussion with, which is what concerns might some people have regarding overutilization in a system, and how might you want to address these concerns as we design a system for the United States with some of these other strategies in mind that we've discussed from other countries. So essentially, you can come up with your own strategies, or you can discuss how the strategies we've talked about could or couldn't apply to our own system.
Thank you all for having some great lively discussions. We thought we would also do a Jamboard that is, I think Shad has already shared in the chat, to just share sticky notes or writings of what you discussed. Actually, we might just jump right into what people have shared. If you can see the screen I'm sharing, it has a bunch of great sticky notes on it.
Great,
I'm sure there are many more. Looks like, you know, some things that are popping out are, you know, increased utilization may represent, we talked about this in our group too, appropriate utilization. In fact, this whole narrative about overutilization might be incorrect, right? Because of what's equitable, what people actually need. Something about unmet needs is much more important than overutilization. These false narratives about overutilization, we have the money to cover everyone. Someone wrote that one person pointed out that people might value the medicine or treatment if they paid a little bit more for it. So that's an interesting tidbit or point. More health educators are needed to help people learn how to self-care. So thinking about Taiwan, it seems that someone really liked that. Providers other than MDs, NPs, and PAs, for example, should probably meet some of these care patients' needs. Something big that's, I know, controversial at the moment. Another group discussed the value of health literacy and a nurse triage line. That's a really cool point. Instead of going through all of them, I'm sure you guys want to jump into some discussion, just jumping off of what I've shared and also what's on the board. If anyone would want to expand on anything they've shared, that'd be amazing.
I can say in our group, we were talking a little bit about the mid-levels kind helping out as well. A big part of not having enough primary care like sort of practitioners available, and so having those nurse practitioners, physicians associates available to help, I think would be helpful. One thing that we were talking about in our group was about how sort of the enhancement of the primary care physicians, how that would probably go pretty well in the United States and under a single payer system. It would help sort of increase that reimbursement rate with primary cares, because now they have a little bit more to do, a little bit more of a load to do. So no one would really question higher reimbursement rate, as well as more people would be going to a primary care more often.
Yeah, I just had some thoughts on the copay. We've discussed this before, and to be equitable, a copay would have to be based on ability to pay, which would require a lot of administrative work. And in a gig economy with people's income changing from month to month would not really be very practical. And so you'd end up probably costing the system more than you would make in discouraging a few maybe unnecessary visits. So we kind of concluded that it's better not to have copays for those reasons.
One thing I could mention, if I could say something.
Go ahead, please, Ruth.
Pardon me?
Go ahead, please.
About maybe encouraging more classes in public schools and in junior colleges, especially about healthcare, so that people have a background and know how to take care of themselves in a better manner.
In Washington, our legislature established a universal health care work group, which firmly came out at the end of their final statement, was given in January this year. And they chose Model A, which is no copays. And now, in this most recent session, 2021, our Bill 5399 passed, and it establishes a Universal Health Care Commission, which has to give its report by November of 22, and will be used to establish the universal health care in Washington, we hope.
Great, thank you for sharing, Kim. Some of the issues around borders and states, like if some states decided that for their culture and in their history and what's going on there, if they thought that copays made sense and another state thought that they didn't justify the expense of setting them up, how does it work for cross-border stuff? But let's catch Marvin first, and then we'll move on.
Yeah, I just wanted to point out that in terms of cost control, preventing patients from overutilizing is only one of many potential cost strategies. And all the other strategies can be enormously effective. First of all, the administrative costs in the insurance industry, that's one. The second is negotiating down prices of drugs and hospital beds and all the other system inputs. The third one is having a single software system provided by the government that's user-friendly, that's well done, and allow everybody to communicate with everyone else. And many other strategies. Recruitment now has been privatized, and it's very, very expensive. It's ridiculous, covering vacations and recruiting new doctors. This could be done much less expensively than is currently the case. It's just on and on and on. For those of you who listen to NPR online, notice that some company named Waystar has been advertising. Healthcare is so complex in the United States that you have all these sectors eating at the trough. For those of you who watch TV, also Joe Namath has been advertising a lot. Any of you notice Joe Namath on television? He's advertising for insurance brokers. That's another completely unnecessary waste in the U.S. healthcare system. So it's not just utilization. There's many, many costs that we can go after. And so it shouldn't be reduced to just that one question. But however, having said all that, I just want to say that it's a great question for the students to put forward and to give a talk on. We didn't have that discussion during the internship, and it was great to see the three of you. I really enjoyed both talks. So I just want to say the interns, you guys are great. And thank you so much for being brave enough to join us.
Thank you, Dr. Malik. Yeah, and absolutely. There's so many other amazing ways to cut costs. This is just one tip of the iceberg.
But this is the one everybody talks about.
Exactly.
So
this is the one
that's a
people
good reason
bring
for
up.
you to bring it up. Yeah.
Right.
And actually, because this is one pair of states, I'm going to switch gears and go back to our presentation to quickly hit another topic that really is just going to be a brief point. Dr. Keller already mentioned to you all that, we wanted to make this other caveat in this whole discussion about, well, what if we go the state-based route, which some of you I know are really more focused on, because maybe you're fed up with the federal government, you don't think it'll work, which is understandable. How have other countries dealt with this that are carved out very similarly? So France, interestingly, just one example, this is how they've dealt with this in terms of cross-border arrangements, because the problem is one question you'll face is, well, what about snowbirds? What about people who come in, set up residency, want to get their cancer treatment, build residency in a state for a few months or a few years? What about those who leave a state and are just, away for 6 months of the year? And there's so many other points that that people have to address that I know the New York Health Act people have been addressing in some of their models. But in terms of the cross-border agreements, I thought it was interesting that the French, what they do is, they have their patients receiving elsewhere costs are taken into account in their budget, and the EU citizens receiving care in France actually brought in, overall, there's a net positive balance of almost $256 million euros. And so this positive balance was actually stable over time, they found. And their providers that they've built relationships cross-border wise with, most importantly, are Germany, Belgium, UK, Spain, and Italy. So they also see this issue with snowbirds, and specifically with Spain, because of the Pyrenees and the mountains there, they've actually set up agreements for using their hospital facilities. The British will actually come because they're supposedly disgruntled with their waiting times. They'll come to seek care in France, but they've also set up that arrangement between the UK and France. And then most importantly, they'll see the most patient traffic with Belgium, with common protocols in place for ER care and quality assurance. And so they've actually had cooperation among four major hospitals in 4 cities that are supported by their statutory health insurance. And there's no prior authorizations needed, so it cuts down on the admin cost worry there. And overall, it's been very functional, and these costs are absorbed and planned for. So this is actually something that could be overall dealt with well if we have to go that approach. And I think some of you being passionate, I know Betty in our group was talking about California care. This is something that maybe you can bring into the fold in conversation when people bring it up as a concern of how you might mitigate this concern if we do go the state-based single payer reform route. But I'm curious to know what others joining us tonight for OPS think, given this solution and how Europe does it, but also if you really think we'd have to go the state-based route versus maybe a more national system.
Yeah, I'd be curious how these cross-border things work. So for instance, if one country does have co-pays and the person goes to a country that doesn't have co-pays, is their country going to be asking them to still pay a co-pay? Or vice versa, if their country doesn't and they go to a country that does, will they then have to pay the co-pay, or do the governments work it out between themselves? I don't know if you got into that level of detail to see how that worked.
I was going to say, I looked into that a little bit, and it does seem they have agreements around co-pays, but overall, they found it was actually more of a waste. It was more of an admin burden. So they reduced that. They took it out.
Well, the idea of collaborating, like making a point of working with hospitals that are near borders, like, in Vermont and New Hampshire, Dartmouth is right there. In Vermont and New York, the Plattsburgh facility is on one side of the river, the tertiary care center at UVM is on the other, and then down in Bennington, there's near Albany. So if you actually went out of your way you could figure out some of your issues around planning, like how many hospital beds does an area need, how many tertiary care beds do you really need. You could be more cost effective if you did more regional planning like that instead of just state by state.
Ro Khanna's bill, state-based universal health care, working on the waivers. kind of implied, and we've been thinking of maybe Washington, Oregon, and California that have similar demographics and join together as three states that would have a universal healthcare system within the 3 states. That's the kind of one of the things his bill is suggesting the possibility of, as I understand it.
Yeah, I think he wrote it to leave that as an option, in case some states wanted to pursue something like that.
So, I mean, I understand the regional. We can actually maybe lesser affluent states, if you want to put it, can do regional, a regional single payer system. If that was the case, if we're trying to, roll it out, the federal government just continues to ignore the needs of the people. The other thing is right now with the health insurance policy, it's not so easy going from one state to another with your health insurance policy. It's a really hard to navigate. And I remember one time that, I was visiting another state and had to see a doctor and had to figure out what was covered, what was not covered, what pharmacy was covered, it was ridiculous. So, we have this problem within our system right now, and it's worse because you don't even know really if you're going to get paid or they're going to get paid. You're up in the air the whole time.
Well, it's also worse because it's not necessarily limited by a state, it's by a network. So you could have, especially in larger states, like Vermont is small enough that it kind of requires that insurances have broader networks so that nobody's more than 30 miles away from the provider, that sort of thing. And then they have to write in contingencies if some of the employees live further away from the ones that would have been in the network. But not all states are that careful, looking out for their residents. But if it were, state by state would actually be an improvement over what we have right now. Are there other thoughts people want to share?
I have a thought on the previous question about copays. And I listen to right-wing radio fairly often. And one of the prime ethics that they bring up in many ways is you've got to work for what you get. And this is a psychological barrier among the conservatives that might be even close to approving us if this appears to be slackers getting something for nothing. We have to counter that somehow.
There's so many misconceptions out there, that so many of the medical bankruptcies are actually people who had insurance and they still went bankrupt because the co-pays and deductibles were so high that it exhausted their actual savings. And that's just doesn't seem to be widely known.
I'm not sure if we're ever going to be able to dispel those narratives with certain conservatives. Unfortunately, I don't think we're ever going to be able to do it. Telling them that, everybody can be insured and you actually will have everybody insured and you will be paying less money and you will be guaranteed your health care, and they still turn around and say, my neighbor's going to get that and they don't work. I don't think we're ever going to get, this is what I'm talking about, embedded in our DNA as Americans. It's also a racism that is a classism that's embedded in our DNA after generations of brainwashing that I'm not sure we're going to be able to get over. So we're going to have to just make ourselves louder, I guess. We're going to have to just make ourselves way louder.
Yeah, I actually wonder how many generations that is. I really think it might be more of us like since the 1930s and maybe not as much before that.
But I do have another comment, which is we've got to see healthcare as something other than a business. We have to see it as a social service.
Before the pandemic, people were always amazed to learn that immigrants pay more into the system than they take out. And in fact, they support the native-born Americans who take out more than they put in. As just a general thing. It still doesn't take care of the woman's neighbor who doesn't work, and they want to make sure that no matter what happens, they don't care what happens to themselves as long as that person doesn't get something he doesn't deserve. But
I just want to make the point that at the end of World War II, in 1945, every country but the United States was so devastated that they made a commitment to social insurance to take care of each other. Only the United States was not devastated by World War II. At the end of World War II, we were so arrogant that we went around the world and told everybody what to do. And everybody else was just saying, oh my God, I'm still alive. I survived World War II. What do we do now? And they turned to each other and hugged and created the Social Democrats. Labor came to power immediately after the war, and they immediately implemented the National Health Service in England. It is the survivors of World War II that made Europe what it is today. It's not America that made Europe what it is today. I'll shut up. That's what I wanted to say.
I just wanted to respond to Michael Huntington's comment because I think that was very salient. We had Dr. Ed Weisbart come and speak to us about deep narratives, essentially, and how the conservative deep narrative is constructed around feeling like you're on a line, waiting for your turn, and you keep getting cut in line. And so it's just interesting, how do we leverage that narrative in such a way that makes them understand our perspective? So I think one thing that works is kind of to explain that everybody else is on the line too, and the line sucks. So like kind of explaining like, well, you or your sisters or your brothers or your parents have probably been in a situation where due to lack of coverage or poor coverage, you weren't able to get the healthcare you needed. How did that make you feel? I think like personalizing the issue could be a really great tool in these conversations.
I was actually going to make a very similar comment as Simran. I think it's a really interesting point that you made. And it goes back to sort of the idea of like benefits having to come from payments, sort of like that free market principle that people believe that healthcare really fits into when it doesn't. Most people, healthcare is one of those things that if one person gets it, everybody sort of gets the advantage of that. And so, yeah, pushing that narrative that Simran was talking about is definitely going to be really helpful.
So this has been really great to have our interns share a small part of what they learned. It was a phenomenal summer, and we're so excited about all the great work that they did. But thank you so much for everybody's contributions tonight, sharing in the conversations, and look forward to seeing you on future OPS office hours again too. Thank you.